next, this data here is for EBRT, the data that's been plotted here. So then you can take data for using brachytherapy, and brachytherapy is implanting permanent implants of radioactive seeds into the prostate, or to treat the prostate. And here are two of the most common radionuclides that are used in brachytherapy: palladium-103 and iodine-125. So here, what this dotted line is showing is that usually when iodine-125 is used, the BNED is about 63%. And for palladium-103, it's about a little above 70. So these dotted lines are saying, we're assuming that using iodine-125 is equivalent to using about 71 grays of external beam radiation therapy. So then you take this assumption of equivalence between iodine-125 and 71 grays of EBRT. And then in this next plot, these curves right here are, this is bed versus alpha-beta ratio. Say if you were to take this expression, remember, alpha-beta ratio is included in RE. So if you take that expression and you plot it, you'd get these curves. Now, for the RE that I've written up here is for EBRT, where you just deliver individual fractions. But when you're using brachytherapy, you're depending on you're using a radionuclide where the dose is decreasing as a function of time. So that has a slightly different RE. So let me just write the expression. That's 1 plus R naught beta over mu plus lambda. This is called Dale's equation. So this R naught is the initial activity. Mu is the repair constant. Lambda is just the decay constant of the radionuclide. And then alpha beta are the usual. So if you use this for RE for the brachytherapy, and use this expression here for the EBRT, and you plot the curves, you would get these curves right here. And this is for EBRT where big D equals 71 grays, and little d equals 2 grays per fraction. Remember, this is the EBRT treatment regimen that's equivalent to using iodine-125 implants. And so, since they have the same BNED, they should also give you the same bed. So where the curves intersect should be the correct value for the alpha beta ratio. And in this case, that comes out to be about 1.5 to 2 grays. So this derivation concludes that this derivation here by Jack Fowler et al. Concludes that the ratio is about 1.5 to 2 grays. And I'm just showing you guys this so that you can think about it yourselves. You think this is a really valid derivation, because there's been some criticism that comparing brachytherapy to EBRT is like, that's the underlying assumption of this derivation, is that we're assuming that this point right here, using iodine-125, is equivalent to using 71 gray of EBRT. So there's been criticism that comparing brachytherapy to EBRT is like comparing apples to oranges. So, all right. So then I'm just going to bring up some of the other opposing arguments against this theory. And the first one here, in the first opposition here, an alpha beta ratio of 3 was calculated, and that was because it was assumed that the tumor begins repopulating much sooner after the radiation therapy. And this other derivation here, it was assumed that the tumor never actually begins repopulating. And in this derivation, they assumed that the tumor begins repopulating about a month after radiation therapy is begun. And so how does this change the outcome of the calculation? Well, in this curve, so if the tumor begins repopulating after about a month, then in the case of brachytherapy, there's less time for the dose to be delivered. And in that case, that shifts this curve. That would shift these curves down because the B-net would be slightly lower. And in that case, you'd get a slightly higher alpha-beta ratio. So you see that the grounds of this calculation already seem to be kind of shaky. But Jack Fowler responded to this paper, and he argues that you can't assume that the prostate tumor repopulates so quickly, because this number of 28 days or 1 month repopulation after tumor treatment begins is mostly valid for head and neck tumors. But you see here in this table that for the prostate is a much more slowly growing tumor. See, this table shows the potential doubling time. I left out the caption, but this table shows the potential doubling time of different human tumors. So you see, the prostate is one of the slowest growing tumors. So this was Jack Fowler's response. You guys can look at the paper yourself to see if you believe him. But that was his response. And then we only have 5 minutes in class today. Another opposition here was a group here assumed that they took into consideration heterogeneity of the tumor into the calculations. I think we've talked about this before in class. Is the linear quadratic model really valid, because it assumes that the entire tumor has just a single alpha-beta ratio? And this group here assumed that that wasn't the case, and they attained a much higher alpha-beta ratio. But I don't have a slide for it, but I like the response that Jack Fowler came back again and came up with another response. And he pointed out that heterogeneity is not assumed in any of the alpha-beta calculations for any of the human tumors that I showed you in the first couple of slides. So it may be the case that all of them may have higher alpha-beta ratios. So we're just questioning the grounds of the linear quadratic model here. And this is the last opposition point I want to bring up. And this is the one that I wasn't able to find convincing enough rebuttal by Jack Fowler to get me back on his side. But this group here, see, the title of the paper is Incorporating Clinical Measurements of Hypoxia into Tumor Local Control Modeling of Prostate Cancer, Implications for the Alpha-Beta Ratio. So this group argues that the tumor is made up of 20% of the cells in the tumor are actually hypoxic, usually. And this may actually be the reason that this may be the cause for bringing the alpha-beta ratio down. Because I think, if you remember, I think the alpha parameter is kind of expresses the intrinsic radiosensitivity, right? Survival fraction is proportional, or the number of cells killed is somewhat proportional to alpha D. So remember, hypoxic cells are very radio resistant, so this might be the reason that alpha-beta ratio is much lower. And then if this is the case, if there is a significant presence of hypoxia in the prostate tumor, then that would mean that hypofractionation would be a very bad idea, because you remember one of the reasons we use fractionation in the first place is to allow for the tumor hypoxic cells to become reoxygenated. So if we used hypofractionation, we wouldn't be taking advantage of that benefit of using fractionation. We wouldn't be allowing hypoxic cells to reoxygenate. And then this is my last bullet point here for the talk, is additional considerations. So one of the things that even Jack Fowler admitted this was that when using hypofractionation, one must keep in mind that because skin is a very early responding tissue, like you'll see in this first slide, that skin has a very high alpha-beta ratio, so it's early responding. So because skin is such an early responding tissue type, if you deliver if you deliver a dose in too short amount of time, there might be a very severe reaction of the acute mucosal epithelium is kind of what makes up the rectum. So that was one consideration they pointed out. But there have been studies, there have been clinical studies where even up to 10 grays per fraction have been used, and they found that there aren't many. The hazards are about the same as using conventional 7-week fractionation regimens. So I think in terms of like this acute mucosal reaction, I think hypofractionation is okay. And then improvements in IMRT are always making it possible to use larger doses. I even saw a number where it said that even down to about using IMRT, maybe even down to 1 cc of the rectum may only receive like 90% of the dose. So not very much of the rectum is exposed to the dose. I remember when computing bed, we assumed that the rectum received all of the dose. And then, so these are my conclusions from looking through all of this and coming up with this report. I noticed that there's been a lot of confidence that alpha-beta ratio is 1.5 at least for the case of low and intermediate risk patients. When you say cancer is high risk, it means that the tumor is more aggressive. It's more likely to invade other parts of the body. So it seems like for low and intermediate risk patients at least, the alpha-beta ratio is indeed about 1.5. There have been numerous studies. And then I really don't know the answer to this point raised with hypoxia. I mean, it's something that it's difficult to really understand what the effect of hypoxia is on the alpha-beta ratio. And that's it. 425.